So I will kick off with the first talk. The first talk is the challenges of CT coronary angiography in veteran athletes, ultimate screening tool. I said to you at the very beginning that sudden death in young people is tragic, and we understand that young sportsmen make headlines, but this bar chart shows you deaths in France during sport between 2005 and 2010 in people aged between 10 and 75. The red bars are our competitive athletes, the sort of people that concern us, and the blue bars are our recreational athletes, and you will see that the vast number of deaths, 94% I should say, occur in middle-aged and older recreational athletes. Now, middle-aged individuals, as far as sports goes, are the fastest growing population of sports people in the world. Here is data set from our participants in the London Marathon, where you see men in blue and women in red, and you will see that the peaks of participation are between ages of 40 and 49. 40% of all our marathon participants are aged over 40 years old. And clearly, these are the sort of people that are more vulnerable to sudden death than our younger counterparts. And when autopsies are performed in older victims of sudden death, by far the most common cause of death is coronary artery disease, which accounts for between 80 and 90% of all sudden deaths in middle-aged athletes. Whereas deaths in young people are due to a diverse spectrum of congenital and inherited abnormalities of the heart that can be detected with ECG, most people with coronary artery disease have a normal ECG. But would ECG actually have a role in older people? We'll talk about that later. So who dies in marathons? It's not the elites that die. It's not them that we worry about. And it's not the costume guys that die. The middle-aged people, the people that die in marathons are these middle-aged runners who are pretty good, who are striving to get below the 4-hour group. So the deaths that occur in marathons are usually in good middle-aged athletes, and that's why it's so important to try and identify these people. And what this slide tells you really is that if you don't want to die during a marathon, just wear a costume and you should be absolutely fine. Now let's talk about ECG screening in older people. This is the largest data set I'm aware of in ECGs in senior athletes. 785 athletes, mean age 47 years, of which 72% were male and 69% were amateur. 5.1% had an abnormal ECG, and here are the various ECG abnormalities. Now, the good news about this slide is that the ECG abnormalities in middle-aged athletes are the same as in young people. So when you examine a middle-aged athlete, you can use the international recommendations to guide your decision-making. They don't have more T-wave inversion, and they don't have any more of Q waves, etc., that you would expect to see in an older person. So that's the one message I want to take away. So how would you diagnose exercise stress tests? And most of you are saying, let's do an exercise stress test. Maybe that may be more useful. Well, in this cohort, 9% of people had an exercise stress test. 3 had already been diagnosed with a cardiac condition. Of all the exercise tests, 5.5% had a positive exercise stress test, and further investigations in this group showed no abnormalities. So in this study, exercise stress test had a false positive rate of 100% in asymptomatic people. This is a larger study of nearly 1,300 middle-aged athletes, most of whom were male, exercised for nearly 7 hours per week, with a low atherosclerotic risk profile and who were asymptomatic. In this case, 4.1% had a positive exercise stress test, and further investigation showed that the false positive rate was 95%. So clearly, if you're exercising someone who's got symptoms of angina, your diagnostic yield will be great. But if you're going to go out and do exercise ECGs in young people, then your diagnostic yield will result in lots and lots of false positive results. So we need something more specific. And that's where coronary artery calcium comes into it. We know that coronary artery calcium is highly prevalent in coronary heart disease. A coronary artery calcium score is a surrogate for atherosclerotic volume. It's associated with higher cardiovascular morbidity and mortality, And progression of coronary artery calcification is a strong predictor of future adverse cardiac events. And we use coronary artery calcium scores for risk stratification and for intensifying therapy for recognized risk factors for atherosclerosis. So maybe one thing that we could be doing for these people is CT coronary angiography or coronary artery calcium scores. So here is data in 318 middle-aged men, of whom 94% had a low ESC 10-year risk score, and these people were good athletes. They were able to achieve workloads of 318 watts. Pretty useful. 52.5% had a coronary artery calcium score of more than 0. And when we look in detail, 16.4% actually had quite a significant raise in coronary artery calcium, more than 100 Agatston units. 8 athletes with a coronary artery calcium score of more than 100 had a luminal stenosis of more than 50%. In total, almost 1 in 5 asymptomatic middle-aged athletes had what we would call significant coronary artery disease, which would not be identified on an exercise test because calcium does not equate to a tight stenosis, but it still suggests that someone's got atherosclerosis. So what we did at St. George's, we tried to do the cleanest possible study that we could, and we tried to get veteran athletes who had no risk factors for coronary artery disease at all. We basically collected athletes who had never smoked, were normal intensive, had a normal lipid profile, and no family history of cardiac disease, and we compared them with controls of who were matched in terms of risk factors. You can imagine how many people we actually had to screen before we identified this cohort. And we subjected all of these middle-aged individuals to a plethora of investigations, and I'd like to just talk to you about the results of the CT coronary angiogram. You will see that these people had exercised for 31 years. 77.5% were marathon runners, with a median number of marathon runs of 13. 16 were national champions, and 5 were world champions. You will note that I've only talked about males and not females, and that's because we did not see any calcium in our females. And you may argue that that's because we matched our males and females hearts get older 10 years later than male hearts. And what we should have done was used females that are 10 years older than the ones we were using. So you found no difference between controls and athletes. But if you look at the coronary artery calcium score of 100, there appears to be a signal towards significance. And you can see that almost 1 in 5 of our male athletes had a coronary artery calcium score of more than 100. When we looked at this in more detail under the microscope, we looked specifically for people with very high coronary artery calcium scores, that is more than 300. And we found that only our veteran male athletes fulfill these categories. 11.5% of our veteran athletes had a coronary artery calcium score of more than 300 compared to none of our sedentary controls who had no risk factors. When we looked at plaques, we found that the prevalence of coronary plaques was twice as much in our athletes compared to our controls. That's 44% versus 22%. And if we looked at the number of plaques in the coronary arteries, 24% of our athletes had more than 2 plaques compared to only 2 of our controls. You can see that our controls are in the blues and our athletes are in the red. And you see multiple plaques are almost confined to the athletic group. When we looked at luminal stenosis, on the x-axis you can see the luminal narrowings, less than 30% to your right and more than 70 to your left and more than 70% to your right. You will see that only our athletes actually had luminal stenoses more than 30%, and indeed 7.5% had a luminal stenosis of more than 50% compared to none of the controls. And this is clearly starts to get a little bit worrying, that people who run a lot seem to have more calcium and more plaques than people who are relatively sedentary. But we then went on to look at the morphology of the plaque, and this bar chart, this box plot is very important. Your male athletes and male controls are compared. The white box equals calcified plaques. The light grey box equals mixed morphology plaque. and the dark grey box equals soft plaque. Now, most of you will be aware that hard plaques are usually more stable, less likely to fissure and cause myocardial infarction. And you will see that our veteran athletes had a much higher prevalence of calcific plaques compared to controls, 72% versus 31%. And what this tells us is that although running and the twisting and torsion and flexing and bending of the coronary arteries probably does cause endothelial damage, it must do, and causes inflammation, the healing process seems to be different to those people who've got hypercholesterolemia or who smoke or who have hypertension, in that these people heal with calcified plaques, and this calcification may mitigate the risk of myocardial infarction and explain why we see such few number of deaths in middle-aged athletes during marathon running. And the hypothesis here comes from studies on, I'll talk about intensity here as well, sorry. This study in Holland was published at the same time as when we published our study. We knew nothing about this study, where they looked at 284 men, nearly 3 times our cohort, and they compared coronary artery calcium scores in those who did 1,000 METs per minute, 1,000 minutes, MET minutes per week, versus more than 2,000 MET minutes per week. And you found that with increasing amount of exercise, fewer people had a coronary artery calcium score of 0. And with increasing amount of exercise, increasing number of individuals had atherosclerotic plaques, just as we found as well. But again, when we looked at the morphology, when they looked at the morphology of the plaques, they found that those people who exercised the most had the highest number of calcified plaques. Okay, so what this is beginning to tell us is those people that do a lot of exercise do get plaques, but in the vast majority of these plaques are stable and calcified. So we think this is stable, and our data comes from lipid studies. We know that if you treat someone's LDL cholesterol, you reduce their risk of myocardial infarction and stroke. And here's a meta-analysis of intravascular ultrasounds looking at atherosclerotic plaque volume in people treated with either no statin, low-intensity statin, or high-intensity statin. And here we see the total atherosclerotic volume, and you will see that people who are treated with high-intensity statin and low-intensity statin get a reduction, a significant reduction in their atherosclerotic volume compared to people who are not treated with statins. So the atherosclerotic volume goes down, but the calcific content of the plaque actually goes up. So not only do statins bring down your cholesterol, we believe that they polymerize calcium within the plaque and make it more stable and make it more resistant to plaque rupture. And this is probably what happens in our athletes. So this is what statins do, and I think this is people who run and heal are healing in this area. We also know that people who exercise and have high coronary calciums do better than people who don't exercise. Here is data in over 8,000 men without cardiovascular disease who had a fitness test and a coronary artery calcium score and were followed up for 8.4 years afterwards, looking for major endpoints such as death, myocardial infarction, and stroke in individuals in 4 categories of coronary artery calcium score, 0 at one end, more than 400 at the other end. If we looked at annual risk of cardiovascular event, it was 0.1% in people with a CAC score of 0 versus 1.9% in someone with a high CAC score. If you looked at mortality, it was 2% in someone with no calcium versus 18% with high calcium. So what this tells you is that even in asymptomatic people, coronary artery calcium is a predictor. But if you are fit, then the risk of cardiovascular events decreases by 14% for each MET increase across all coronary artery calcium scores when adjusted for risk factors. So you can have calcium in your arteries, but if you're fit, you're less likely to stroke out and have a myocardial infarction. And I'm telling you all of this because you will be seeing athletes coming to you saying, I had a CAC score which has come back at 120, and now I'm petrified and I don't know what I should be doing. So, what should you do when you are faced with a veteran athlete who's got a high coronary artery calcium score? Well, the first thing is to tell them that You look at the morphology of the plaques. Are they predominantly calcified? How fit are they? If they're predominantly calcified and they're fit, you probably don't have to do very much other than address any risk factors that they have that could be treated. And if they do have a raised cholesterol, you will treat it. Agreed? And guess what will happen to their coronary artery calcium score a year later? It'll paradoxically go up. So our advice is once you've treated the cholesterol, do not repeat the coronary artery calcium score, okay? Because it'll only cause panic and confusion. So where we are at the moment is that coronary artery calcium scores are very useful in people who have got intermediate risk of adverse events for coronary artery disease and are very good at identifying those people that you should be treating aggressively. Their role in cardiovascular screening of athletes is controversial, considering that I've just shown you that athletes get more calcium in their arteries than non-athletes, and we still don't know what the significance of this is because there have been no long-standing studies. So until we know that, we need to do this. Look at this. This is deaths in a middle-aged population. 5% deaths occurred during exercise. The male-to-female ratio was 19:1. So males are much more likely to die during recreational sport than females. Most deaths were witnessed during sport. CPR was started early during sport, and so was an AED applied early during sport. And these people were more likely to live if they're arrested whilst playing sport. We know all that. But look at this. 16% had pre-existing heart disease. 50% had at least one risk factor. And 36% had typical symptoms of cardiovascular disease in the prior week. So I want to leave you by telling you that the first thing that you do is advise your athletes about risk factors for coronary artery disease and the warning symptoms. That's very, very important. And the second thing that we should all be striving for is making sure that we're all prepared for sudden cardiac arrest and have availability of AEDs. I think that is the way forward at the moment with preventing sudden death in middle-aged athletes. So thank you very much for your attention.